Hi! Welcome to Road to 250. Today we will be going over the vasculitides. So let's get started with some basic principles. So what is vasculitis? It is an inflammation of the blood vessel wall, and the arterial wall is composed of 3 layers: the endothelial intima, the smooth muscle comprised media, and the connective tissue comprised adventitia. So the cause for vasculitis is usually unknown, and most cases are not infectious. Can anyone tell me what some of the general clinical features of vasculitis are?
ESR.
Okay, and what does ESR kind of tell you? Like what?
Inflammation.
Yes. And what are some symptoms?
Inflammation of the blood vessels. And then we can think about transudate, exudate.
Okay.
Edema.
Okay. And what kind what kind of symptoms do we see when we think of inflammation in general?
Ischemia. Okay, symptoms of.
Just you think inflammation. What symptoms are you thinking of? What?
Fever.
Fever, yeah. Anything else?
Pain.
Okay. Fever, yes. Pain, such as myalgias, all that stuff. You can also see weight loss and fatigue going on. And like you said, you do have some symptoms of organ ischemia again with vasculitis. And that will be due to either narrowing of the lumen or thrombosis of inflamed vessels. Okay. So the vasculitides are divided into 3 categories: large, medium, and small vessels. Can anyone tell me what large vessel vasculitis involves? What vessels are involved here?
Arterioles.
Bigger.
Carotid aorta.
Aorta. So the aorta and its major branches like the carotid artery, yes. How about medium vessel vasculitis?
Arterioles.
Still a little bigger than that. This one talks about just muscular arteries that supply organs in general. And for small vessel vasculitis, now we have
Arterioles.
Arterioles, capillaries, and venules. So all of that. The much smaller ones that are closer to participating in gas exchange. Okay. So any questions about this before we move on to talking about the different large vessel vasculitis?
No.
Okay. So there are 2 types of large vessel vasculitides. So, I did not want an arrow. Just remember, for large, there are 2. The first one we're going to talk about is giant cell arteritis, also known as temporal arteritis. This is a granulomatous vasculitis, and it involves branches of the carotid artery. It is the most common form of vasculitis in older adults over the age of 50 and usually affects females. Some symptoms we can see here is it can present as a headache. It's involving the temporal artery, hence temporal arteritis in the name. Some visual disturbances if it's involving the ophthalmic artery. Just underline that there. And jaw claudication. You can also see some flu-like symptoms and joint and muscle pain as well, which can kind of look like polymyalgia rheumatica. And like Tulsi mentioned before, you see your elevated ESR, which will usually be over 800. On biopsy, you can see an inflamed vessel wall with giant cells and intimal fibrosis. So this is the image here. Let me see. So this is our intima here. You can see signs of inflammation here. We see all these neutrophils coming in. There are giant cells over there. And then of the intima, all of this portion is our fibrosis. I'll just mark that with an F. And there is that. Lesions are segmental. You do need a biopsy of a long segment of the vessel for diagnosis, but a negative biopsy does not necessarily exclude disease. So do require it, but if it's not present, it doesn't necessarily mean that this isn't happening. And to treat this condition, we can use corticosteroids. And if you're not treating it appropriately, there is a high risk of blindness, especially with the ophthalmic artery involvement here. Okay, so the second type of large vessel vasculitis is Takayasu arteritis. And this one is also a granulomatous vasculitis, up there, which involves the aortic arch at its branch points. It is present in adults under 50 years old. So if we remember the other one, over 50, and here we have under 50. And this one also occurs in females, more classically young Asian females, and can present with visual and neurologic symptoms with a weak or absent pulse in the upper extremity. So this is also cutely known as pulseless disease. And again, the ESR is also elevated here because you have inflammation going on. And treatment for this guy is also corticosteroids. And I like to think of this one as the ninja disease because of it affecting young Asian females, and you have a weak or absent pulse that you can't tell, so your pulse is being sneaky like a ninja, if that helps anybody. That's how I remember it, but there you go. And this is from first aid, so just to go over these two one more time so we really have it in our heads here. Giant cell Takayasu, we got two large vessel vasculitides, both affecting females. This one elderly females, and this one Asian females. First aid says younger than 40, Pathoma says 50 is a differentiation, so let's kind of stick with first aid for now. And again, symptoms here, you got the unilateral headache, jaw claudication, can lead to blindness with ophthalmic artery occlusion, and you remember associated with polymyalgia rheumatica when we mentioned the joint and muscle pain that occur as well. And again, branches of the carotid artery. There is focal inflammation, increased ESR for both of these. You're all going to use corticosteroids for both of these. I'm going to Takayasu just one more time, pulseless disease. You can also see the symptoms of inflammation with fever, myalgias, and some other symptoms. You can see night sweats, arthritis, skin nodules, and ocular disturbances. And then this one also has granulomatous inflammation with thickening and narrowing of the aortic arch. So as you can see kind of here, we got some thickenings and some narrowings going on. And yeah. So any questions about these two before we move on to our medium vessels? Okay. So now on to our medium vessel vasculitides. And here we have 3. You see our numbers going up. We had 2, now we have 3. Starting with polyarteritis nodosa. Ooh, sorry. Okay. This is a excuse me, necrotizing vasculitis that involves multiple organs, except the lungs. These are spared here. This will classically present in young adults as hypertension, because it involves a renal artery, abdominal pain with melena, because it can involve the mesenteric artery, and neurologic disturbances and skin lesions as well. So if you remember before, we were talking about medium vessel vasculitis. It involves the muscular arteries that supply the organs, so we can see that occurring here. You can see lesions of varying stages at the same time. And also now this is associated with hepatitis B surface antigen in the serum. Okay, so lesions of various stages can be occurring at the same time. Usually early lesions will consist of transmural inflammation with fibrinoid necrosis. So you can see the inflammation going on within here, and kind of occurring with this fibrosis that's healing, that'll produce this string of pearls appearance. So you connect these, you got a nice little string of pearls going on. That's what we have there. Treatment is corticosteroids and cyclophosphamide. So if you remember our previous 2 for our large vessels, it was just corticosteroids. So now we've added a second drug here. And this is fatal if left untreated. Our second type of medium vessel vasculitis is Kawasaki disease. This affects Asian children less than 4 years old and can present with nonspecific signs such as fever, conjunctivitis, rash of palms and soles, enlarged cervical lymph nodes, all that stuff there. This can involve the coronary artery pretty commonly, and that will lead to a risk of thrombosis with myocardial infarction, as well as risk for aneurysm with rupture. So this is very concerning here. Treatment is with aspirin, and one of the only times we would prefer using aspirin in children, because dealing with this disease is a little more important than worrying about Ray's syndrome. And you can also use IVIG as well, but usually the disease is self-limited. Can anyone tell me the most of note concern with Ray's syndrome? What symptom are we most worried about?
Microsteatosis? Tinnitus? No.
Encephalopathy, actually. So we're more I'm going to stop right here because that's a very long word to spell and I'm doing it poorly, but there you go. Yeah, we're concerned with encephalopathy, but in this case, we want to prevent any of these from happening more than Reye syndrome. Okay. And our last disease of the medium vessel vasculitides is Buerger's disease. And this is a necrotizing vasculitis that involves the digits. It will present with ulceration, gangrene, that can result in autoamputation of the fingers and toes, as well as Raynaud phenomenon. Again, all things relating to your fingers and toes. This guy is very heavily associated with smoking, and treatment is quite as simple as smoking cessation. And one more time for all three of these through first aid. So again, there was 3 here. Polyarteritis nodosa, usually middle-aged men. Again, there's a hepatitis B seropositivity going on. Got some non-specific symptoms of fever, weight loss, headache, etc. You can see GI symptoms. If it affects those GI organs, then you can see abdominal pain, melena. You can also see hypertension, neurologic dysfunction, cutaneous eruptions, renal damage, etc., etc. This will typically involve renal and visceral vessels, and again, here the lungs are spared. So, does not affect the pulmonary arteries. And again, there is transmural inflammation with fibrinoid necrosis going on. You can have different stages occurring at the same time. And on arteriogram, you see down here, you can see renal microaneurysms. Let me see a little hard to see here, but little microaneurysms going on, and spasms as well. And again, you want to treat with corticosteroids and cyclophosphamide. And then we have Kawasaki's disease, also known as mucocutaneous lymph node syndrome. Again, Asian children younger than 4. You can see rash on palms and soles, cervical adenopathy, some additional symptoms. You can see strawberry tongue, and foot changes, additionally to fever and conjunctival injection as well. A mnemonic that first aid mentions is crash and burn to help you remember some of these symptoms here, and burn for fever. And again, can develop coronary artery aneurysms, or which can result in thrombosis or rupture, leading to death. So that's a no-no. I'm sad about that. And we want to treat with IVIG and aspirin. This is where aspirin has a special use in children. And last, one more time, Buerger's disease, also known as thromboangiitis obliterans, seen in heavy smokers, or males less than 40. And this affects the fingers and toes, so you can have claudication that can lead to gangrene and autoamputation of the digits, as well as superficial nodular phlebitis. Well, and Raynaud phenomenon is also often present because of this as well. And treatment here is smoking cessation. So, any questions about these 3 before we move on to small vessels?
Nope.
Okay. So now we have our small vessel vasculitides. So we saw 2 types of large vessels, 3 types of medium vessels. So now that we're at small, we're going to have 4. It's a little easy to remember, 2, 3, and 4. So we start with Wegener's granulomatosis. And what we have here is another type of necrotizing granulomatous vasculitis. And this involves the nasopharynx, lungs, and kidneys. The classic presentation, you can see a middle-aged male with sinusitis or nasopharyngeal ulceration. You can see hemoptysis and bilateral lung infiltrates and hematuria. So again, we have nasopharynx, the lungs, and the kidneys being involved here. And hematuria can be due to rapidly progressing glomerulonephritis. Some key distinguishing factors here. We have serum C ANCA levels that are present, and they will correlate with disease activity. So higher levels, higher disease activity going on. And on biopsy, we can see large necrotizing granulomas. So we have this very large area of necrosis going on with adjacent necrotizing vasculitis. So there's have our giant cells going on here as well. And treatment for this guy is cyclophosphamide and steroids, just like we saw with polyarteritis nodosa. And relapses are common here. Our second type of small vessel vasculitis is microscopic polyangiitis. This is also a necrotizing vasculitis that involves multiple organs, especially the lung and kidney. The presentation is pretty similar to Wegener's granulomatosis, but nasopharyngeal involvement and granulomas are absent. So, do not see these two. And here we have serum P ANCA levels instead of C ANCA levels that correlate with disease activity. And treatment is pretty much the same, corticosteroids and cyclophosphamide, and relapses are also common here. Our third type is Sturge-Strauss syndrome. This is also a necrotizing vasculitis, but this one has granulomatous inflammation with eosinophils that involves multiple organs, especially the lungs and heart of note. You can see asthma and peripheral eosinophilia, eosinophils, in this condition. And this one also has serum P ANCA levels that correlate with disease activity. And last of our small vessel vasculitides, we have Henoch-Schönlein purpura. So just pretend there's these little dots above the O. This is a vasculitis due to IgA immune complex deposition. So a little special here. It is the most common vasculitis in children. Here you can see palpable purpura on the buttocks and legs. You can also see GI pain and bleeding, as well as hematuria from a IgA nephropathy. And this usually occurs following an upper respiratory tract infection, where you have IgA developing after this infection that then deposits into your kidneys, and then you got this vasculitis going on. The disease is self-limited, but it can reoccur, so you do want to treat with steroids if it gets severe. And one more time with first aid. So our 4 small vessel vasculitides. We have Wegener's, also known as granulomatosis with polyangiitis, a special extra name there. Again, this affects the nasopharynx, the lungs and the kidneys. So you can see upper respiratory tract problems with perforation of the nasal septum, chronic sinusitis, otitis media, mastoiditis. That you can see lower respiratory tract problems with hemoptysis, cough, dyspnea, and renal issues as well, such as hematuria and red cell casts. Classically, you'll see the triad of focal necrotizing vasculitis, necrotizing granulomas in the lung and upper airway, and the glomerulonephritis as well. And again, the serum signs we see here is C-ANCA, which is also known as PR3-ANCA or antiproteinase 3. And on chest x-ray, you can see large nodular densities. This is our C-ANCA right here. And again, you treat with cyclophosphamide and corticosteroids. We have our microscopic polyangiitis. This is also our necrotizing vasculitis. That is different than our Wegener's because it does not have nasopharyngeal involvement, but it will involve the lung, kidneys, and skin with a posse immune glomerulonephritis and palpable purpura as well. Again, no granulomas. And this one has P-ANCA positive in serum, which is also known as MPO-ANCA, so you can see either or, and can also be known as anti-myeloperoxidase. So important to know all three of these versions because you can see any in questions. And this is what our P-ANCA looks like here. P. And treatment for these two are the same, cyclophosphamide and corticosteroids. And then we have Scherg-Strauss, which is also known as eosinophilic granulomatosis with polyangiitis. So a little similar to this name, except we have lots of eosinophils going on. So eosinophilia. Symptoms here, again, include asthma, sinusitis, skin nodules or purpura, and peripheral neuropathy. That can present as wrist or foot drop. Can also involve the heart, GI, kidneys. Again, you also see a posse immune glomerulonephritis going on. And this one also has P-ANCA serum levels as well as IgE level increase. And of note here, this has a special triad as well of asthma, the vasculitis that's occurring. Sorry about that. Asthma, vasculitis, and let's see, it's on here. The third is allergic rhinitis. So I'll just leave that there. And last of our small vessel vasculitides, we have our Hemlock Schonlein purpura. Again, the most common childhood vasculitis, systemic, often follows an upper respiratory infection, and this one also has a classic triad of palpable purpura, arthralgias, abdominal pain. This one is secondary to IgA immune complex deposition and is associated with IgA nephropathy, also known as Buerger's disease. Note Buerger's, not Buerger's, because that is one of our medium vessel vasculitides, so just note the spelling difference here. Very different. And yeah. So any questions about these guys before I move on to some practice questions for us?
Nope.
Okay. So I'm going to go ahead and start with a pretty short one. Skin biopsy from the thigh of a child demonstrate vascular lesions with IgA and C3 deposition. The most likely clinical presentation for this patient would be which of the following?
B.
Yeah, I agree.
B is correct. So what condition does this child have?
Post-stroke. Good pastures.
Enoch Schulin purpura.
Yes.
Oh, it's IgA. Sorry. Yes.
Yeah, so just looking at vascular lesions with IgA, that's our key diagnostic factor here. And like I mentioned before, the triad for Henoch-Schönlein purpura includes the palpable purpura on the butt and legs, as well as abdominal pain, and does anyone remember the third one?
Arthralgias?
Yeah, arthralgias. I'll just add that there. Cool. And our last question. A 55-year-old man is hospitalized with abdominal discomfort and black stools. He is treated empirically with antibiotics and acid-reducing medication, but upper GI endoscopy does not identify any abnormalities and his symptoms resolve. Several weeks later, the patient returns to the emergency department with fever, weight loss, and muscle pains. Past medical history includes asthma and hypertriglyceridemia, for which he takes appropriate medications. He also has smoked a pack of cigarettes daily for 30 years and has abused intravenous drugs on multiple occasions in the past. After initial evaluation, a muscle biopsy demonstrates transmural inflammation of the mid-sized arteries with areas of amorphous eosin-stained arterial wall necrosis. Areas of internal elastic lamina disruption are also present. Which of the following is the most likely predisposing factor for this patient's current condition?
Smoking?
Yeah, D.
Answer is actually viral hepatitis. So, this person has polyarteritis nodosa, and we can tell that he has that because of his episodic GI, muscular, and systemic symptoms. So we have GI symptoms, fever, weight loss, muscle pain, systemic symptoms, and we also know that it is a medium vessel vasculitis, and it mentions that biopsy has a transmural inflammation going on, which is also characteristic of polyarteritis nodosa, and there is eosin-stained arterial wall necrosis. So when we talk about that, we are talking about fibrinoid necrosis going on. And there are also areas of internal elastic lamina disruption. So you see different processes going on, so different stages of inflammation occurring. Yeah, so we have our general symptoms, our abdominal pain, our melena, asthma, hypertriglyceridemia, etc., etc. So these are all kind of like a few signs that'll point to the diagnosis of polyarteritis nodosa, and with PAN, what we can note here is that in about 30% of patients, it is associated with hepatitis B surface antigen. Okay, and both of you guessed smoking, and that is associated with which vasculitis?
Berger's disease?
Buerger's disease. So it's
Diabetes. No.
Yep, it's Buerger's disease. So that one is highly associated with smoking. But you'd see symptoms associated with the digits. So I'm going to draw a very terrible hand here. So you'd be concerned with claudication and ulceration of your fingers and toes, or limbs, and it will spare the vessel wall, so the internal elastic lamina would not be disrupted for Buerger's. And just to clear up the other ones, choice A, antibiotic use, would be related to microscopic polyangiitis, which is our small vessel vasculitis. Well, that's not what it is. And asthma is associated with Churg-Strauss, or otherwise known as eosinophilic granulomatosis with polyangiitis, and that's also a small vessel vasculitis, so not here again. And triglyceridemia on its own can cause acute pancreatitis that can lead to abdominal discomfort, but arteritis is not really associated with this guy. Any questions on this? I can try explaining it a little better if you like.
Nope, you're good.
Okay. So basically, takeaway from here is polyarteritis. The DOSA affects multiple organs here, except the lungs. And again, you can see transmural inflammation with fibrinoid necrosis, and again, 30% of patients do present with serum anti-Hep B surface antigen. And that's all I have for you.